the introduction and for demonstration for the OncoKB and what it can do. And there are workshops and classes on how to use C-Bioportal, and Nikki puts in a lot of effort into this, so please use it as a tool. And for fellows and researchers in the room and clinicians, it's really great. And it's actually linked to the HIS, so when you're seeing a patient and an impact was done, you can click on the C-Bioportal icon so that you can make sense of the genomics that were reported in the pathology report. So with that introduction, I will tell you a little bit about how we use this data in clinical practice. And globally, gastric cancer, Kohei is in the room, is a major burden, as Laura Tang mentioned to you. I mean, this is a Godzilla of cancers. While in the US, it's relatively orphan disease. This is a conference that we just recently came back from in Yokohama, and this is how gastric cancer is viewed worldwide. In addressing it in a multidisciplinary approach with gastroenterologists, pathologists, surgeons, and so on is really the way to do it. This is Daniela Molina here. So by way of overview, we'll talk about the therapeutic implications of MSK impact as a predictor of chemotherapy resistance, the mutational burden, and what that story tells us about immunotherapy, resistance and heterogeneity in HER2 amplified tumors, and we'll finish with a segue into liquid biopsies and as introduction to Dr. Diaz's talk, which is coming up next. So to focus your attention, I think it's important to bring it back to the patient. This is a woman that we saw in clinic, T3N1 G junction tumor that was diagnosed at a local institution in Brooklyn. The tumor is HER2 negative, and as Nikki mentioned, beyond HER2, at the time there was really no validated biomarkers in gastric cancer. And this is a G junction tumor, and there was no evidence of metastasis at the time. This is an endoscopic ultrasound showing a locally advanced cancer. The standard of care for these patients is to treat them neoadjuvantly with chemotherapy and radiation, and that's what she received. And unfortunately, while on therapy, the patient developed biopsy-proven retroperitoneal and bulky supraclavicular lymphadenopathy, rendering her M1 and incurable. At that point, she came to MSK seeking a treatment, and so we transitioned her to a standard of therapy, FOLFOX therapy. And unfortunately, again, within months on therapy, she suffered rapid and symptomatic disease progression, echoing some of the cases we heard this morning, where she was unable to eat, needed a feeding tube, and so on. So beyond genomic spectrum that Nikki described, really the prognostic significance of SYN tumors, which is what you would typically expect her to be, this patient, as a G junction cancer. 69% of these tumors are chromosomally unstable, aneuploid, and really are difficult to treat, as they have overlapping multiple genomic alterations in a single cancer. And as you can see here, generally these tumors do poorly compared to MSI and Epstein-Barr virus tumors, which are more immunogenic and as a result tend to do better even outside of therapy. What we know about MSI tumors particularly is, though, although stage for stage they generally have a better favorable outcomes, they actually don't respond that well to chemotherapy. This is a cohort of patients from the cancer discovery paper that we just published, and again, showing in a small cohort of patients, only 7 patients, and so this is hypothesis generating at best, but the hazard ratio of patients receiving first-line FOLFOX therapy was 0.4, and they blow through chemotherapy very quickly. And similar data has been presented by Lizzie Smith from the MRC group, looking at OS in preoperative MAGIC study. Patients who were MSI high and actually received chemotherapy, and this is the orange line here, did significantly worse compared to the MSI patients that went straight to surgery, suggesting, at least in this small cohort of patients, that you can potentially hurt your patients if you don't know that they're MSI and they're receiving aggressive pre-op therapy. These patients got epirubicin, which is also quite toxic. In another cohort of patients from mostly Asian study, the classic study, also in adjuvant setting, this was recently published in Annals of Surgery, Again, not as pretty of a picture, but you get the idea. The red curves here are MSI tumors, and patients who had surgery alone versus people who got chemotherapy and surgery. In this cohort, at least, it doesn't look like chemotherapy is hurting the patients, but they're not helping. And Sebastian Mondaca recently published an opinion piece from our group on this in the Annals of Surgery, again, suggesting that perhaps in stage 3 tumors, stage for stage, since they do so poorly, we can't move away completely from chemotherapy outside of immunotherapy options, but maybe we should target them with other drugs, at least in the setting of a clinical trial. So the general theme here is that MSI tumors are chemotherapy refractory. Well, going back to our patient, lo and behold, again, G-junction tumor, not a typical location for an MSI cancer, but she was MSI high, and again, due to promoter hypermethylation, this was not a germline Lynch case. And in 2013, she received treatment with nivolumab on the CheckMate 32 study, and really had a dramatic response to therapy within just first 2 doses. And at the time of acquired resistance, when she started developing progression of disease, the systemic disease was still under control. The primary tumor started to grow, and we biopsied it, and we did note a beta-2M mutation that was unique to the progressive cancer. At that time, we took her back and re-radiated her tumor. I think either Karen or Abe were brave enough to radiate the tumor again with concurrent capecitabine. And similar to the case you heard this morning, the squamous cell case, she had quite a bit of symptomatic dysphagia, was not able to eat, was really failing. And so Dr. Rush, similar to Daniela's heroic effort this morning, took her to the operating room. And amazingly, this was a PathCR, YPT0 and 0 tumor. And effectively, this woman is cured now almost 5 years after initial diagnosis. We were lucky with her. She's young and fit and was able to sustain 2 lines of therapy and chemoradiation while we were, not aware that her tumor was MSI. So typically and ideally, we would learn about this early on and not, because often, if the patient's presented at a later stage, and even with MSI cancers, it's too late to reverse the progressive disease, especially in gastric cancer, where it can be quite dramatic and aggressive. Young Lee and Luis Diaz published and has been really instrumental in getting pembrolizumab FDA approved, and this is recent science paper looking at solid tumors across diseases, and overall response rate is quite dramatic. And what I always find most interesting about this waterfall plot is the unknown primary. There's an unknown primary response, which again goes to show that we really should characterize these tumors across disease subsets and try to get them to immunotherapy early on. So MSI tumors are rare in gastric cancer, and if you don't see enough gastric cancer, to you it could be considered, a unicorn, maybe not worth looking for, but it really should be assessed early on and as early as possible in metastatic or even locally advanced disease due to high activity, usefulness in clinical practice, and chemotherapy resistance, particularly since in early stage tumors, the incidence is higher. Beyond MSI mutation, MSI status, mutational burden may be a factor. So it's not just a factor of getting MMR, IHC done and being, and satisfied and not having to do NGS. So sequencing offers the continuum of mutational burden. And here are the data that we presented, and Jeff Koo is going to be updating in a separate manuscript that cutoff of 9.7 mutations per megabase may be predictive of outcome with immunotherapy, and those are the patients that may benefit beyond MSI status. This is a recent Korean paper published in Nature Medicine looking at response according to MSI status. And again, we've had a dramatic and cured patient with Epstein-Barr virus subset in our cohort of MSK impact patients. But because ABV was not originally included on MSK platform, we did not have additional cases captured. But in this paper in Nature Medicine, they also report dramatic responses in EBV-positive tumor with pembrolizumab monotherapy. Interestingly, Kohei has shared data with me that suggests that perhaps EBV tumors are not as immunotherapy sensitive. And our patient actually had a complete response to dual anti-PD-1 and CTLA-4 blockade. So, but this Korean data suggests that EBV subset of patients are also important to target with immunotherapy. So high ctDNA mutational burden is also a factor that we can focus on, and this data is somewhat controversial and is still in development, but very interesting that looking at beyond MSI status, mutational burden in the circulating tumor DNA can identify and predict patients who may respond. Particularly, the proportion of ctDNA change is predictive of response, as shown on this waterfall plot here. Of the proportion of initial change in the circulating tumor DNA mutational burden. So with that, we are launching this phase 1 pilot study of patients in MSI-high tumors across solid tumor subsets, looking at patients who have resected MSI-high tumors. And again, those patients tend to do well, so it's very difficult to do an adjuvant study in these patients. And so we're selecting for a population of patients who are the most likely to recur, and patients who have circulating tumor DNA persistent after completion of standard chemotherapy and surgery. And those patients are randomized to receive adjuvant pembrolizumab versus placebo. And this trial really has been brought here by Luis Diaz and the Precision Prevention program that we're focusing on to help cure our patients or increase our chances of cure. Shifting gears for the last few minutes, we'll talk a little bit about HER2. As you know, HER2 is a validated biomarker in esophageal gastric cancer. TRASTUZUMAB is FDA approved in combination with chemotherapy, but unfortunately we're not curing our patients. And the first-line chemotherapy trial in combination with pertuzumab has failed to improve outcome over TOGA monotherapy. Why is that? Well, we're building on the breast cancer literature, and in gastric cancer, it's a unique subset of tumors, perhaps different biologically than breast cancers. And Jackie Heckman has really done an amazing job helping us review these cases histologically and from a fluorescent in situ hybridization method. So this is the testing algorithm. We start with immunohistochemistry. If the tumor is HER2 positive by IHC, we stop and consider it clinically positive. For tumors that are equivocal or 2+, we do fluorescent in situ hybridization, and HER2 amplification of FISH ratio of greater than 2 is considered positive. Why are some people not really truly HER2 dependent, though? And in the TOGA study, you can see that the benefit of trastuzumab first-line therapy is not quite as dramatic with gastric cancer as it is in breast. What we find in gastric cancer, there are quite a bit of tumors that have very focal positivity of HER2 on clinical samples that may not be clinically significant in terms of actual dependence on HER2 for signaling. And this is a cohort of patients that received first-line trastuzumab therapy in standard practice and all had next-generation sequencing. And as you can see here, if the threshold of HER2 amplification was not high enough to meet the positivity cutoff on by the MSK impact, the patients behaved as if they were HER2 negative, even though those are patients that you and I would consider HER2 positive in clinical setting. They were IHC 3+ or FISH positive. Further, that patients with positive tumors by impact but had co-occurring alterations in RAS, RTK activation, as Nikki showed, which are common in SYN tumors, also did not do as well. These are the green and the blue curve. And only if you really had a high level of HER2 amplification by impact and were relatively wild type on, for other alterations did you do dramatically better. And even though the curves eventually cross, they are quite separate. So up to 30% of tumors that are HER2 positive actually have these resistant biomarkers in primary setting. So what do we do with that? Well, the idea and the way we're moving forward is to combine anti-tumor blockade with immune checkpoint blockade. Trastuzumab, we all think, works through mostly immunotherapy-related effects such as ADCC. And what's interesting, even though T-cell response is activated, the tumor counteracts it by overexpressing PD-L1 and trying to suppress it. So, and pembrolizumab can enhance this T-cell immunity. And furthermore, chemotherapy actually helps enhance dendritic cell presentation and may also have additive benefit. And this is preclinical data that panned out in the transgenic mice with HER2-positive breast models, which was published in 2011. This was an MSK-initiated clinical study that came out, and we put it through an LOI as soon as the first Pembro data came out in gastric. And as you can see here, just combination of trastuzumab, pembrolizumab, and chemo. And this is the waterfall showing dramatic responses. And what the sequencing data shows actually in this cohort of patients where we did not mandate primary confirmation of HER2 at MSK, so as long as someone came from any hospital with HER2 positive pathology report, they were allowed to go on the study. Only 56% of these patients were actually HER2 amplified by impact. So we were not cherry picking our patients, and so these responses are somewhat hopeful. The survival data is not yet mature, so hopefully these will impact our outcome. And so based on this data, Keynote 811 study is going to open this month. And we're also put in a R01 grant in collaboration with Nikki, looking at mechanisms of predictors of response, of acquired resistance, and the primary resistance for this combination. Acquired resistance is a big issue, and that's why we're trying to move to first-line setting to try to improve our chances of response and cure in these patients, because right now there's no HER2-directed agent that has been successful in second-line setting. TDM1 failed, lapatinib failed, and unfortunately the landscape is quite bare. What we know about acquired resistance is events that we saw in primary resistance just happen more often in acquired resistance. So loss of HER2, activation of RAS and PI3 kinase pathway. And what else we know is that even in patients that respond, there's quite a bit of heterogeneity between the primary tumor and the metastasis in the co-occurring alterations and the level of HER2 expression. This paper was just actually accepted to Cancer Discovery today. Francisco has, this is wrong. Francisco Sanchez is the first author on this. And what we found, you saw the data from Thomas this morning, and showing heterogeneity of HER2 on the trastuzumab PET scan. And for the first time, Francisco was able to demonstrate the heterogeneity of molecular heterogeneity that corresponds with this imaging heterogeneity. As you can see here, these are the 3 metastases that responded in a different way in this patient. And what was unique to the resistant tumors is that they were the only ones that lacked co-occurring EGFR amplification. So in this cohort of patients, we demonstrated that EGFR amplifications were important in predictors of response to certain HER2-directed agents in second line. Well, Steve Marin is in the room. He's our newest recruit to our group, and him and Adam Bass's lab has really been instrumental in looking at spatial heterogeneity in a similar fashion. So our cohort was an autopsy cohort. These are serial biopsies and also cell-free DNA analysis with Guardant 360 assay. And divergent primary tumor and metastasis were noted, and the cfDNA really helped detect that. And so these are, again, going back to the work that Luis Diaz is doing here, and Steve Marin will also join, will be key to identifying mechanisms of resistance to HER2-directed and other targeted agents in gastric cancer. This is, again, a paper that Steve recently published looking at serial tissue and cfDNA sequencing, looking at quite a bit of heterogeneity across different driver alterations. That is a big roadblock in the drug development in gastric cancer, and we need to address because beyond these very modest 2 months improvement in survival, we need to do more, and that's the rational design trials is the way to do it. So I will stop and with conclusions that we did demonstrate some benefit for multiplex fashion in a way to look at all the alterations that can occur and maybe drivers such as EBV and MSI tumors in impact analysis. And since this EBV is actually added to the new panel update that Mike Berger is doing, Having this genomic footprint allows you to identify ctDNA alterations that are happening in the bloodstream and may help us non-invasively monitor these patients. These combination strategies with both targeted agents and immunotherapy are the wave of the future. And there's a lot of work to be done. You know, to Sophia Stadler's talk this morning about germline alterations, we really need to try to identify it in a better fashion, these homologous repair deficiency signatures. And that was, I didn't have time to show it, but on impact, that was an unsuccessful attempt to do that. And for HER2 tumors, there's quite a bit of heterogeneity. We're looking at combination strategies and, again, the imaging and cfDNA analysis to really target this complex disease biology. And single target inhibition is just not enough in this cancer, and we need to focus on future and the combination strategies. And that's it. Thank you.